when to do and when not to do. I think, yeah. Over to Vishwa.
Thank you, sir. Uh, Good evening, all my consultants as well as my colleagues. Today, we are going to talk about coronary artery revascularization, the latest guidelines put forward by the American College of Cardiology, AHA, American Heart Association, as well as the American Society of Angiography and Intervention. This was published in 2022 January in the edition of Journal of American College of Cardiology. So it's a very long guideline. So I'm going to speak about only the salient features in these guidelines. So it's important to first get these concepts into your mind. First thing is this surgeon term can be replaced by the cardiologist as always. So a good surgeon, good cardiologist will know how to, but the better ones will know when to, and the best ones will know when not to. So same goes with intervention. So the most important thing is to know when to and when not to in the case of intervention. So that is mainly the focus in my lecture today. This guideline was published in 2021 December and published in the 2022 January edition of Journal of American College of Cardiology and put forward by ACC, AHA, and Society of Coronary Angiographers and Interventionalists. This is the writing committee. So level of, we are mostly going by ESC guidelines. However, this is a American guideline, which is similar to the ESC guideline in one case. The strength of recommendations all are like the same, like class 1, class 2A, class 2B, class 3, and harmful. And also the quality of evidence is slightly different to what we are used to. We are used to level A, but they have levels like as A, B are that where there is randomized trials, and level B is there is evidence, but there are no randomized trials. So there's a slight difference from what we are used to in our guidelines. So outline of my topic, we are talking about revascularization here. So revascularization, we'll talk about first the acute coronary syndromes, the STEMIs and the non-ST elevation acute coronary syndromes. Then we'll discuss about the more controversial topic of chronic coronary syndromes and what to do. And in the chronic coronary syndromes, I would like to specifically talk about these groups of subsets of patients who have low EF, who have low impaired LV ejection fraction, who have whose EF is more than 35, and then left main coronary artery block versus non-left main coronary artery, and triple vessel disease versus non-triple vessel disease. This bulk will cover the majority of the presentation, and then a few slides about the technical considerations during PCI as well as during CIBG. Okay, so before starting the main topic, these important things are shared in the guidelines, that is the decision making and informed consent. The patient should be at the center of the decision. Revascularization decision should be taken in consultation with all the parties as well as the patient center, and should be patient centered. And also the informed decision making should be done. This is a same thing. Informed consent is patient is at the center, and it's shared decision making, not what we tell, but we should ask what the patient wants as well. And the next important thing is the heart team. The heart team consists of mainly the patient as well as all the cardiologists, the cardiac surgeons, and the other ancillary staff as well. So this heart team decisions are taken not only during peri-procedural, but peri-procedural as well as the post-procedural time period as well. Okay, so with that in mind, we'll dive into STEMI, revascularization in the setting of ST elevation myocardial infarctions. So revascularization of infarct-related artery in a patient with STEMI. So first I'll discuss when to do PCI in STEMI. So if the patient, this color coding matches the level of strength of recommendation, right? Green means 1, yellow means 2A, orange means 2B. Sorry, 2A, orange means here 3B. So scheme in a patient with STEMI, PCI should be done if the ischemic symptoms are of less than 12 hours of onset. That is primary PCI. That is class 1A recommendation. Also, there is class 1A recommendation when there is failed thrombolysis for rescue PCI. And also there is class 1A recommendation for cardiogenic shock or hemodynamic instability, irrespective of the timing of the STEMI or thrombolysis. So that is class 1A recommendations in STEMI for PCI. So the class 2A recommendations come for PCI when there is successful thrombolysis after initial presentation, but they undergo routine early angiography with intention to perform revascularization. That is within 24 hours they should have PCI. That is class 2A recommendation. Also, there is a place for PCI in STEMI for the late presenters. Late presenters in this sense is the patients who come to us within 24 hours of symptom onset, but after 12 hours. That patients, even though they are asymptomatic and stable, they have a place for primary PCI. That is, however, class 2A recommendation. And there is another class 2A recommendation for the patients who are having ongoing ischemia, ongoing severe left ventricular heart failure features, acute pulmonary edema, or refractory, or who has features of electrical instability, that is arrhythmias, irrespective of the onset of symptoms. So these patients also we should take in for PCI or with the intention of revascularizing, irrespective of the time of onset of the STEMI. And there's another recommendation of 3B where PCI is of no benefit. That is for the patients who are asymptomatic and who are asymptomatic and late presenters who come after 24 hours of onset of symptoms, and on angiography they have a completely occluded vessel. That in that case PCI is of no benefit. We'll discuss all the evidence for these recommendations as we go along, right? So when do you do CABG in STEMI? What are the indications for CABG? Emergency CABG is required in STEMI in the case of mechanical complications, such as VSDs, such as ruptured papillary muscle or infarcted papillary muscles, and if there is ventricular free wall rupture, and if the case of if the patient is in cardiogenic shock and the PCI is not feasible, if then in that case emergency CABG is warranted in the case of patients with STEMI. However, there is a class 2A recommendation for CABG in patients whom primary PCI is not feasible or failed. These patients, I mean, do not have cardiogenic shock or any mechanical complications, right? But their PCI is not feasible or had failed, and there is a large area of myocardium at risk. These patients should undergo emergency CABG, emergent or urgent CABG. That is a class 2A recommendation. However, emergency CABG is harmful in the case of patients who have failed primary PCI, especially if there is poor distal targets and if there is no reflow. Especially no reflow phenomenon is very common after PCI, especially primary PCI. In those patients, even when there is in that setting, emergency CABG is deemed harmful. Right. So with this in mind, we'll go into the evidence. So what are the evidence for primary PCI? That is multiple randomized trials and meta-analysis are there to support primary PCI to reduce death, myocardial infarction, stroke, as well as major bleeding compared with fibrinolysis. And especially in the setting where the treatment delays are minimized. And fibrinolytic therapy is only recommended when the primary PCI is not immediately available and the delay from the hospitalization to PCI is anticipated to be more than 120 minutes. However, it's important to note that success rate of fibrinolysis is about 70 to 80%. And out of that 70% of who succeed also, about 10% of people do not have TIMI3 flow in the infarct-related artery. So overwhelmingly, evidence is favoring primary PCI for acute STEMI. So then what about STEMI and cardiogenic shock? There is evidence from the 1999 shock trial where they compared the primary endpoints of survival in patients with STEMI with cardiogenic shock. Initially, they did not improve with revascularization at 30 days, but at 6 months, there was mortality. There was secondary outcome of 6 months. They had lower mortality in the groups that was revascularized compared to the conservatively managed group. Hence, in STEMI and cardiogenic shock, revascularization is recommended irrespective of the time of STEMI. That's again a class 1 recommendation. So what about hemodynamic support in shock? Hemodynamic support is a class 2B recommendation that is either Impella or IABP as a adjunct to PCI in selected high-risk patients. It's a class 2B recommendation. Randomized trials have shown no benefit in the composite outcomes of death, MI or CVA or repeat revascularizations in patients whom IABP or Impella has been used. So what about rescue PCI? Rescue PCI or early PCI, early angiography with intention to revascularize should be done, especially rescue PCI should be done if there is failed reperfusion after fibrinolysis. That has been associated with reduced cardiovascular events shown in multiple meta-analyses. And routine early angiography after successful thrombolysis also shown to reduce MACE. So how do you minimize bleeding here? Especially you can use half-dose tenecteplase in elderly. Use radial access is preferred, and if possible, try to avoid glycoprotein 2B3A inhibitors. So what about the evidence of STEMI with late presentation? So STEMI presenting after 12 hours of onset of pain with evidence of ischemia, shock, heart failure, or life-threatening arrhythmias, they should undergo PCI. However, this recommendation does not have any randomized clinical trials because it's not ethical to do randomized trials in this setting. What about STEMI late presenters who come within 12 to 24 hours without any evidence of shock, arrhythmia, or heart failure or ischemia? In these patients who come within 24 hours, invasive strategy has been shown to reduce the left ventricular infarction size compared to a conservative strategy. And also it has been shown to reduce the 4-year mortality rate compared to the conservative strategy in the BRAVE trial. Hence the recommendation, there's a 2A recommendation. Patients with who are late presentation of STEMI within 24 hours has to have can undergo primary PCI with intention of revascularization. It's a class 2A recommendation. However, this late presentation should be balanced with the potential harm of opening a totally occluded artery in a latecomer, especially when the latecomer comes about more than 24 hours late. which is demonstrated in the OAT trial. And therefore, delayed PCI of an infarct-related artery, which is totally occluded, should be deferred. And PCI should be considered only if there is a flowing artery in patients who come after 24 hours of symptom onset, without, the important thing is here, without any evidence of ischemia, LV failure, cardiogenic shock, or arrhythmia. If the patient is stable, no chest pain, after 24 hours, you do the angiogram, find a completely blocked artery, leave it. Right. So hence, if you want to recap, primary PCI, failed rescue PCI, cardiogenic shock, all are class 1 recommendations. Late presentation and stable patients, or after from successful fibrinolysis, or patients having ongoing ischemia, arrhythmias, irrespective of time duration, it's a two-way recommendation for PCI. However, patients with totally occluded arteries after 24 hours, you should not do PCI. That's a 3B recommendation. Right. Now let's see patients who we have done the primary PCI to the infarct-related artery. What if they have multivessel disease? What do we do next? So then the next important question is the patient in shock? If the patient is in shock, come out. Do not attempt PCI to non-infarct related arteries if the patient is in cardiogenic shock. This is a practice changing update which comes after the 2007 with evidence from the 2017 culprit shock trial, right? Which is changed from the 2017 STEMI guideline, which recommended the PCI to be done in non-IRAs in cardiogenic shock. Which is now the practice should be changed, and it's recommended in this revascularization guideline after 2007 on the basis of the evidence from culprit shock trial. So in this trial, it was clearly shown that culprit only strategy had improved primary endpoints such as all-cause mortality and renal failure requiring renal replacement therapy benefit, as well as 1-year mortality benefit, as well as rehospitalization with heart failure. It was seen. So if the patient is having cardiogenic shock, only PCI to culprit artery. So if the patient is not having cardiogenic shock, then what are our options? If the patient is having the patient is not in shock, we have successfully done the infarct-related artery, then non-IRA lesions can be treated in 4 different ways. One is single setting PCI. You do the other vessels at the same time as the primary PCI, or as staged PCI. You do it, but at a later time. And then there is FFRO ischemia guided revascularization option is also there. And the other option is primary PCI to the IRA with elective ZABG. So let's see when to do what to do in each of these settings. So there's a class 1 recommendation for staged PCI of significant non-infarcted non-IRA stenosis to reduce the risk of death or MI. It's a class 1 recommendation. So if the patient is not in patient is not in shock, then other vessels should be stented. Now the problem is when. So here's other recommendations. The patients with STEMI with complex multivessel non-IRA disease, then elective CABG should be done in order to revascularize and to reduce the cardiac events. However, this recommendation is a new one. There's a class 2B recommendation that is a weak recommendation to do the non-IRA arteries at the time of primary PCI in selected group of patients. That is a class 2B weak recommendation, but still it's a 2B recommendation. This other one I spoke about, if there is shock, it's harmful to do the non-culprit lesions. So there's again a change of practice from early 2017 ESC STEMI guidelines. So where does this evidence come from? It comes from the non-infarcted related artery revascularization evidence comes from the complete trial in 2019. It showed that combined endpoint of CV death, reduced CV death or MI in staged PCIs of non-IRA was done when the staged PCI of non-IRA was done. This was shown to be similar when in patients who had early non-IRA PCI, the median that was 1 day, or after hospital discharge, the median was about 3 weeks. So irrespective, the timing of the non-IRA lesions, PCI for non-IRA lesions was 45 days. Should be done within 45 days according to this complete trial. So as you can clearly see here, the primary outcome had reduced cardiovascular death or MI, reduced cardiovascular death, ischemia-driven revascularization or MI, as well as secondary outcome reduction of NYHA class 4 heart failure as well. All were reduced when there was complete revascularization. Timing, this according to this trial, was done within 45 days, but this can be done within 1 day as well as can be done after 3 weeks as well. However, there's a small caveat for this trial. This evidence from the complete trial, when you go through the patients, you see only very little amount of patients with critical left main disease, and also these patients had more low complex disease. That also should be kept in mind when you interpret this trial. So then there's a weak 2B recommendation to do PCI of the non-IRA at the same setting as the primary PCI. In whom should we attempt this? This should be done in a select group of patients who fulfill 4 criteria. 1, successful PCI to the infarct-related artery. 2, should have normal LV function. 3, should have normal renal function. 4, should have low complexity non-ischemia-related artery disease. So if your patient fulfills all 4 of these criteria, there's a 2B weak recommendation that they can undergo non-culprit PCIs at the same time of the primary PCI. Okay, so that completes revascularization in STEM. So next topic would be revascularization in non-ST elevation acute coronary syndrome. So the most important thing here is to stratify the risk. So, and stratifying the risk is the most important thing for the timing of invasive strategy. So in a patient who comes with a non-ST elevation ACS, first you assess whether the patient is clinically is having very high risk. So what is very high risk clinically? The patient is having cardiogenic shock, or the patient is having refractory angina or hemodynamic instability. If the patient has either of these, immediate invasive strategy should be taken to care within 2 hours. So if the patient is not having either of those 2, then of course you have to evaluate the risk. That evaluation of risk, we have various risk stratification tools. So you use those risk stratification tools and then determine whether this is a high risk for the clinical events or whether there is an intermediate or low risk. If it is a high risk clinical event, then early invasive strategy should be done within 24 hours. If there is intermediate to low risk, then invasive strategy should be done before the time of discharge, ideally within 72 hours. This is how non-ST elevation ACS is revascularized. All depends on the risk stratification. Clinically high risk, clinically moderate, or very high risk, and intermediate to low risk. very high risk by cardiogenic shock or hemodynamic instability. These are risk stratification tools that we commonly use. Right. So non-ST elevation with cardiogenic shock, again, the same principle, evidence coming with the culprit shock trial, only the infarct-related artery. Do not touch the others. Right. So is there a place for CABG in NSTACS? There is. If the anatomy is not suitable or not feasible for PCI, they have to have CABG. Or in the case where there is failed PCI with ongoing ischemia, hemodynamic compromise, or there is and there is substantial myocardial risk, they should have CABG. That is, however, a class 2A recommendation. Right. Now, the clear-cut territory is done. Now we are going towards uncharted waters. Revascularization in chronic coronary syndromes. It's a very controversial area. The guideline committee itself is confused, and surgeons are against these recommendations. So let's see. So revascularization in chronic coronary syndromes, I would like to take mainly two arms into account here, right? One is the symptomatic mandate, where you revascularize for a symptomatic purpose. And then the other one is the prognostic mandate, where you revascularize for a prognostic mandate, prognostic indication, right? So first we'll take the easy one. We'll take the symptomatic mandate. That means we revascularize to improve symptoms. That is a class 1 recommendation here. So in a patient with refractory angina, right, despite maximum medical treatment and with significant coronary artery stenosis, refractory angina, despite optimum medical treatment and with significant coronary stenosis, patients should undergo revascularization in order to improve symptoms. That is the symptomatic mandate. It's a class 1 recommendation. However, if the patient has angina, but there is no anatomic or physiologic criteria for revascularization, we should not do anything. That will cause harm. Class 3 recommendation. So the symptomatic mandate, it's quite easy. Have refractory angina, despite optimum medical treatment, significant coronary stenosis, revascularize. Right, now the difficult part. Anatomic indications to improve survival or the prognostic mandate. Right, so this diagram itself looks complicated. So what we'll do is we'll take it piece by piece and try to summarize it. Right. First, we'll take a subset of patients with a class 1 recommendation for CABG. Patients with whom we are thinking of a prognostic mandate, and patients with EF is low, EF less than 35%. When the patient has EF less than 35% and multivessel coronary artery disease, there is a class 1 recommendation for CABG. So low EF, severe triple vessel disease without left main, with or without left main can be this. We are talking about without left main. Multivessel CAD, low EF CABG. Why? The evidence comes from the STITCH trial. STITCH trial takes in patients with EF less than 35% and triple vessel disease, and they compared CABG versus optimum medical therapy. And however, at 5 years, there was no statistically significant difference, but at 10 years, there was statistically significant difference in death from any cause, death from cardiovascular causes. and also death from any cause or cardiovascular hospitalization. Everything at 10 years showed statistically significant difference. Hence, low EF, multivessel CVD, CABG, class 1 recommendation. Right. Now the more controversial part, which a change of practice is coming. Right. So we'll look at patients who have either a normal ejection fraction with multivessel disease or who has slightly mildly impaired left ventricular ejection fraction with multivessel disease. Right. So patients with stable ischemic heart disease, normal ejection fraction, and significant stenosis in 3 major coronary arteries with or without proximal LAD. Here, the important thing is we are not talking about left main. I'll talk about left main separately. Here we are talking about non-left main disease, right? So non-left main EF either normal or mildly impaired EF, right? So patients with stable ischemic heart disease, normal ejection fraction, significant stenosis in 3 major coronary arteries with or without LAD, proximal LAD. We don't consider proximal LAD any significant now. Whose anatomy is suitable for CABG. CABG may improve survival. This is a class 2B recommendation. Earlier, this was class 1 recommendation. Now it's a 2B recommendation. Significant downgrade. Then, patients with stable ischemic heart disease, again, normal ejection fraction, significant stenosis in 3 major coronary arteries with or without proximal LAD. I told you we are not considering proximal LAD anymore after a certain trial. And anatomy suitable for PCI. PCI usefulness is uncertain. So it's not sure. Even the guideline committee is not sure. So that's why they are recommending. It may be useful, may not be useful. It's a 2B recommendation. However, this patients with stable ischemic heart disease and EF mildly reduced EF. EF is around 35 to 50 with triple vessel disease. CABG may be beneficial. That's again a 2A recommendation because they say the Lima graph to LAD, because of this survival benefit comes because of the Lima graph to the LAD. Hence, there's a 2A recommendation for CABG here. But if there is normal ejection fraction with triple vessel disease, either CABG or PCI, the benefit is controversial. It's a 2B recommendation to revascularize, but since for PCI, the recommendation is survival benefit is uncertain. Right, same thing here, stable ischemic heart disease, 3 vessel disease, no left main disease, normal EF, PCI, CABG versus OMT. There is no advantage. Comes through the recommendation of one single clinical trial, that is the ischemia trial in 2019. Right. See, I have mentioned what I told you earlier. This class 2B recommendation, which represents a downgrade from the class 1 recommendation in 2011 CABG guidelines in the US, as well as the 2018 revascularization guidelines of the ESC. All shows one recommendation. I'll come to that. This reflects new evidence showing advantage of CABG over no advantage of CABG over medical therapy to improve survival in 3 vessel coronary artery disease with preserved EF and no left main disease. This earlier class 1 recommendations were based on mainly registry studies and a single randomized trial, which was done many years ago, according to them. This is, I directly quote from the the guideline supplementary document. And they have, and also the new evidence from ischemia trial, as well as a new meta-analysis, which includes the ischemia trial, supports this downgrade according to the guideline writing committee. Right. So let's discuss this practice changing ischemia trial in detail. International study of of comparative health effectiveness with invasive and medical therapy, the ischemia trial. So these patients were stable patients with at least with moderate ischemia, right? Stable patients in the sense they have excluded acute coronary syndromes, and then they have demonstrated moderate ischemia. Ischemia was demonstrated either by exercise ECG or with cardiac MRI, perfusion MRI, echo with regional wall, or with the SPECT scan showing more than 10% of LV ischemia of LV left ventricle, 10% left LV area of ischemia. And then these patients, but the primary aim was to determine whether initial invasive strategy of CAT plus PCI or CABG or medical therapy will reduce events compared to a therapy of compared to a strategy of medical therapy alone, right? So initially they did ischemia testing and found out who had moderate ischemia, and then they had a blinded CT coronary angiogram. Why did they have a blinded CT coronary angiogram? This is to exclude left main disease as well as to exclude non-obstructive coronary artery disease. So there were some exclusion criteria. Recent ACS was excluded, CKD was excluded, but CKD was included in ischemia CKD trial, and severe heart failure, medically refractory angina, and unprotected left main all were excluded in this ischemia trial, right? So let's see what is happening here. So about 8,000 patients and 3,000 were excluded. So 5,000 underwent randomization. And then out of that, about 3/4 underwent a CT coronary angiogram. And however, about 25% didn't undergo CTCA. Out of that 25% also, about roughly 700, about 50% had known coronary anatomy by angiogram. So they did not undergo a CT coronary angiogram, and then about another 700 did not have angiogram because CT coronary angiogram because they had other issues. And out of that, roughly 2,500 each, 2,600 were each randomized to a invasive arm or a conservative arm. And then it's important to see that out of the invasive arm, here out of the invasive arm, about 80% underwent revascularization. That means out of the invasive arm, about 20% were there on medical therapy as well. And out of the medical therapy group, about 25% underwent angiography and 21% underwent revascularization. So roughly in both arms, there were crossovers. From this side, there was about roughly 20% who underwent revascularization. And from this end also, roughly there was about 20% who had medical therapy alone. Right, so outcomes, there was, it's a negative trial in a sense. There was, the check for the primary outcome was CV death, MI, resuscitated cardiac arrest, or hospitalization for unstable angina or heart failure. There was no statistically significant difference. And secondary outcomes were cardiovascular death or MIs that also had no statistically significant difference, as well as the all-cause death. It did not have a statistically significant difference. These are the famous charts from the ischemia trial. The important thing here is myocardial infarction. In the invasive arm, initially myocardial infarctions were high, but around 2 years after revascularization, there is a crossing of lines you can see. So this initial rise in the invasive MIs in invasive arm was mostly due to the procedural MIs. However, after about 2 years, this rise in the non-invasive arm was due to spontaneous MIs. Right. So there were some criticisms of this ischemia trial. Again, what I highlighted earlier had been a criticism of this trial. they say early MIs due to procedural MIs, and then later 2 years, after 2 years, there was the MI rate was similar in between. Then the conservative strategy quietly overtook the invasive strategy. And what if you follow them up over a longer period of time, what will happen is yet to know. So we don't know what is happening in that sense as such yet. So, and also there's the crossover revascularization or 21%, but that was mostly balanced from either side, right? So this is the summary of the ischemia trial. It's a mainly negative trial, which demonstrates in patients with demonstrable ischemia and no left main disease with normal ejection fraction, stable patients, medical therapy versus invasive therapy, that means either CABG or PCI, there is no significant difference in primary or secondary outcomes. So hence there is downgrading of the PCI recommendations earlier, which said class 1 recommendation for PCI in triple vessel disease or CABG in triple vessel disease, which has been downgraded now to a 2B recommendation, right? And then patients with stable ischemic heart disease. So what if patients with stable ischemic heart disease without LAD involvement? So this again downgrade of recommendation. Patients with ischemic heart disease, normal LV ejection fraction with 1 or 2 vessel CAD not involving LAD, revascularization is not recommended here. So again, this comes on the basis of the ischemia trial. Let's go through the data. See, coronary artery disease severity based on 50% stenosis at CTCA. All these people who had this side is the invasive strategy, this side is well, always crosses the line 0. So there is no statistically significant difference between this. What about the proximal LAD? Here, proximal LAD earlier was a class 1 recommendation for PCI or CABG. And now again, proximal LAD more than 50%. Again, there is no statistically significant difference between conservative strategy and intervention. So hence, what is the proximal LAD? Is it any different from any other coronary arteries? According to the new revascularization guidelines, it's a P recommendation. Again, they say usefulness of revascularization to improve survival is uncertain. So this chronic coronary syndrome has, can you all hear me?
Yes. Can hear.
Right. Okay, sir. So hence the recommendation is downgraded from earlier 1 recommendation to a 2B recommendation, where the benefit of revascularization is uncertain. Okay, so patients with more than coronary, patients whom have either less than 70% or FFR, not significant FFR by lesion, it's not recommended. It's harmful to revascularize them. That's nothing new. So let's go and discuss. So there is a significant downgrading of recommendations for chronic coronary syndrome from triple vessel disease, normal ejection fraction. Revascularization benefits are now uncertain on the basis of this ischemia trial. LAD, non-LAD disease, simply you should not do PCI. As the benefit is not benefit, whether it's improved survival is uncertain. And even proximal LAD lesions, revascularization, the benefit is uncertain. Right, so we'll go on and check the left main and the complex diseases. Right, so we discuss about significant left main stenosis and complex coronary artery disease. What is the revascularization here? So patients with stable ischemic heart disease who have significant left main stenosis, remember left mains were excluded in the ischemia trials, hence we don't want that ischemia trial bothering us anymore. Left main diseases, CABG has a class 1 recommendation. However, in patients whom PCI can offer a similar equivalent revascularization to CABG. PCI also is reasonable to improve survival. That is a 2A recommendation. So this is a little controversial here. Provide equivalent revascularization. Whether our PCI would provide equivalent revascularization? Sometimes yes. So that is a point here. So stable ischemic heart disease with left main CABG is beneficial over optimal medical therapy. Evidence comes from old studies, veteran administration, coronary CASS study, and cooperative study. Right. So when to decide whether it's CABG or PCI, then comes the issue of complexity. Right. So when to decide CABG, when to decide PCI, when there is complex disease, severe tortuosity, thrombus, trifurcation, bifurcation, complex bifurcations, aortosteal lesions, heavily calcified lesions. When there is complexity, CABG is preferred over PCI. Evidence comes from multiple trials. I will talk about few. Syntax trial, about 1,800 patients were involved who had complex coronary disease, and median syntax was high in these patients, and average stent length was 86 millimeters in these patients. Then PCI versus CABG outcomes at 1 year as well as 5 years. MACE was reduced in the PCI. MACE was high in the PCI patients. CABG was better for the complex coronary artery diseases, as demonstrated in the syntax trial. Also, a newer trial, the FAME3 trial. This trial is a fairly recent trial which demonstrates FFR guided PCI with second generation stents. Remember, syntax had first generation stents, and FAME3 has second generation, and syntax did not have FFR. FAME3 has FFR. FFR guided PCI versus CABG for complex triple vessel disease. Here, the important thing is non-left main. It did not involve left main disease. Again, what they have shown is, conclusions wise, overall, CABG was better for triple vessel disease than second generation DES with PCIs. And however, it depends when you analyze the subgroups here. The MACE was based on the syntax score. Patients with low syntax score, less than 23, PCI was better than CABG. But the contrary, the patients with high syntax score more than 32, CABG was always better. So this PCI versus CABG for complex coronary artery disease, there are multiple trials, syntax, Excel, pre-combat, and the meta-analysis all showed that CABG slightly holds an advantage over PCI for complex PCIs involving left main than CABG. Hence, there is a recommendation for complex disease in patients whom require revascularization. For significant left main with high complex CAD, it is recommended for CABG over PCI to improve survival. High complex with left main, but patients with multivessel CAD who have high syntax also, it is generally preferred for CABG over PCIs to confer a survival advantage. When there is left main with complex disease, it's a class 1 for CABG. When there is no left main but the complex high syntax lesions, it's a 2A recommendation for CABG. So here's the change of practice that I had talked about earlier. You, on your right side of the screen, you see the 2018 Revascularization. Can you hear me?
Yes, yes.
Right. One vessel CAD, two vessel CAD, three vessel CAD, all were class 1 recommendations for PCI, CABG or PCI, CABG or PCI, again PCI, CABG, right? In the 2018 guidelines, all were class 1 recommendations, which had been downgraded to 2B recommendations here. Multivessel CAD 2B, left main, stenosis of proximal LAD 2B, and multivessel CABG 2B, multivessel PCI 2B, and single vessel no LAD, no benefit. So there is a significant downgrading of previous recommendations based on the findings of the ischemia trial. What will happen in the future is yet to be known, because we don't have ischemia trial just ended, published its data in 2019. So long-term follow-up of ischemia patients yet to be, what will happen is yet to be answered. We'll see. Here's the change in recommendations. Right, so there is now the main bulk of this presentation is done. So we'll just have few slides on few other aspects touched by this guideline, which is a vast guideline, which includes DAPT, which I have completely ignored here. I'm not talking about DAPT in this during this talk. So diabetes with CAD, same recommendation stands. CABG is beneficial over PCI in diabetics with involvement of LAD, because the Lima graft over LAD has a prognostic benefit. However, if the CABG is high risk, or if there is problems with CABG, PCI can be considered as an alternative. It's a 2A recommendation. So it comes from the Freedom trial, which had shown all-cause mortality is higher in PCI compared to CABG. So revascularization in special groups. This is an interesting recommendation. So for non-cardiac surgery, patients with non-left main or non-complex CAD who are undergoing non-cardiac surgery, routine revascularization is not recommended, solely to reduce the preoperative cardiac events, perioperative cardiovascular events. So patients who are undergoing routine surgeries, non-cardiac surgeries, who don't have any left mains, you should not do anything for them. And there's an interesting recommendation about CTOs. CTO also has been downgraded. Treatment of CTO for the prognostic mandate has been downgraded. Patients with suitable anatomy who have refractory angina on medical therapy after CTO, after treatment of non-CTO lesions, benefit of, even for the symptomatic mandate, the CTO lesions are now downgraded to a 2B recommendation. Benefit of PCI for the CTO is uncertain. That comes with this trial, the decision CTO trial in 2019. There was no significant difference between death, MI, or any at composite endpoints at 4 years after CTO PCI or non-CTO PCI. However, what the EuroCTO study shows that there is reduction, improvement of quality of life following CTO PCI. But the recommendation still stands as 2B recommendation. CTOs, even despite them having refractory angina, the usefulness of PCI, CTO PCI is uncertain. So let's talk a bit about general procedural issues here. So vascular access for PCI is always radial preferred. Stent selection wise, drug-eluting stents should be done, should be over BMS, and IVES and OCT should be used when there is complex coronary settings to identify mechanism of stent failures, sometimes for optimal lesion preparation, and to determine stent sizing and expansion as well. And also to evaluate complications, OCT is useful. So radial access has multiple meta-analysis and multiple randomized clinical trials showing benefit of radial access. And a little bit about the periprocedural medication. GP2B3A receptors. So GP2B3A receptors are recommended as a 2-way recommendation when there is high thrombus burden, no reflow or slow flow. They can improve procedural success rate. However, it's only in acute coronary syndromes. There is no place for GP2B3A in chronic coronary syndromes. There is no benefit in using GP2B3A receptors for in chronic coronary syndromes. And then this is also an important aspect, periprocedural anticoagulation. This is in patients undergoing PCI, unfractionated heparin, there is a class 1 recommendation. And also, if the patient had an NSTACS and patient is on enoxaparin, patient had an non-STEMI and patient is on enoxaparin, then peri-procedurally, rather than heparin, they asked to consider enoxaparin, IV enoxaparin. The dose, what they are saying is patients who had the last dose of subcut enoxaparin about 8 to 12 hours earlier, and if only one dose of enoxaparin has been administered, then it's about 0.3 milligram per kg of enoxaparin. Then if the last dose was administered within 8 hours and the patient had more than 2 doses of subcut enoxaparin, they recommend not to give any enoxaparin at the time of procedure. This is for us anyway, this is not applicable as we don't have enoxaparin now. Right. So general procedural consideration for CABG, this arterial grafts are already preferred over venous saphenous venous grafts. There's a controversial issue here because they are now recommending radial artery and Lima as the same class 1A recommendation for Lima for the LAD as well as radial artery for the other vessels. And epiaortic ultrasound also is recommended. There's a class 2A recommendation to see whether there is any plaques in the ascending aorta to reduce the incidence of. So do everyone like these guidelines? Apparently not. Surgeons are against it. The American Association of Thoracic Surgeons and the Society of Thoracic Surgery, they are up in arms against this. So they have had special webinars, special content. It's all over YouTube. They are saying why they are not endorsing these guidelines. Why do they not like the guidelines? They have mainly 3 objections. One, because they have downgraded the recommendation of CABG from 1 to 2B to improve survival in 3-vessel coronary artery disease, preserved ejection fraction. They don't like it. As well as the recommendation of downgrade from CABG from 1 to 2A for EF less than 50 patients. Because of those 2 things, they are against these guidelines. And also, the other objections are similar weight is given to PCI and CABG for revascularization to decrease the ischemic events. They are saying that CABG is better than PCI. And also, there are equal preferences given for Lima and the other graphs. So that's what that's another objection that they have. So all in all, it's a controversial guideline. It's open to discussion now. Thank you very much.
Thank you, Vishwa. I think you have covered a very extensive area, but simplified it by compartmentalizing the conditions. I think initially to 3 settings, and then even within the same setting, you have nicely, directed the more complex guidelines. Actually, these guidelines have changed our practice. And also you have given us some idea about trials that drove the change in practice guidelines. So thank you very much, Vishwa. So are there any questions?
Yeah, Vishwa, can you hear me?
Hello, sir.
Gota, you are there?
Yeah. I'm sorry, I couldn't join you at the beginning. I'm on holiday.
Okay.
And
nice
yeah,
right.
Good one. I think this the latest guidelines, so that's the way it is. And I'm very happy that you did it. It's a very complicated one, so little here and there confusions, but you straighten it up and then put it in perspective clearly, and it's very simplified manner. So that's great, Vishwa. I'm very happy and proud of you. Good, great.
Thank you.
I think one of the parts that we have left behind in the whole discussion, it's always, as the topic tells, it's about revascularization. One of the modalities that the interventional cardiologists and the cardiac surgeons are, very interested at. But most important part that we can't leave behind, even the topic is revascularization, is optimization of the medical therapy. That is even ischemia trial. That is the cornerstone or the more or less default strategy of treating patients with chronic coronary syndrome. So that is also very important, because even if anybody happens to survive acute coronary syndrome, if they are lucky to survive with all them, some of them are lucky because we have very effective therapy to tackle STEMI as well as non-STEMI interventionally. And so if they happen to survive, and the way forward for them is mostly most of the patients is optimal medical therapy. So that in acute setting, that has to be coupled with I think cardiac rehabilitation program to introduce all this behavioral therapy. And so that is one of the things in ischemia trial. I think they define the stable patients post ACS 2 months into post ACS. So that is one of the things that after a complicated plaque event, patients can get at least the arteries can get stabilized within 2 months. Of course, naturally, maybe with our secondary prevention therapy as well. So that is one of the things that has to be kept in mind, not to be forgotten.
I have a question, if that's okay. Zupul here.
Yes, Upul.
Does anyone know whether these new guidelines have caused a reduction of the numbers of PCI and coronary artery bypass graft surgery in Sri Lanka or in the rest of the world? Speaking to colleagues, I don't get that impression, but I would like to hear from others as well. Thanks.
I haven't seen any publication into that effect. Anybody else?
Upul, there is regarding this OAT trial, even in US, they have done a study in US, and it clearly shows the practice has not changed after EOT trial. That means they do PCI to asymptomatic patients even after 24 hours. The rate has not gone down. So basically, it has no impact on the practice. So we don't have data here, but the situation can be more or less similar.
Thanks. Okay. Thank you.
So the setting that STEMI patient coming acute STEMI, then coming very late, maybe 48 hours later, but asymptomatic now, and echo shows a mildly reduced LV ejection fraction, maybe 45%. That subset are they being addressed in the guidelines?
Yes,
Not clearly.
they have not specifically mentioned, sir, but what they are telling is asymptomatic patients without any of the four things: this electrical instability, no acute left ventricular dysfunction, without any ischemia or without any arrhythmia. Then if those four conditions are fulfilled and there is a completely occluded artery, only.
No, what I mean is,
do
we have to, in that setting, say that 48 hours later, do you have to rush for angiogram at that stage to know the coronary anatomy, or you assess the viability and other factors and residual ischemia? Or what do you think?
Ideal setting angiogram is necessary, since
in
ideal setting.
All the patients.
All the patients following acute coronary syndrome.
Then to decide
whether to open them up,
revascularize later.
Later, yes. Resource poor settings, of course, we can improvise, but
issue of viability.
Viability comes if we know the anatomy. If we don't know the anatomy, then we can't.
The concept of viability is not been introduced there, no? The guidelines?
No, sir.
Not incorporated, no?
No.
into the guideline now?
No.
What are you there still? Mayura, if there are no questions, shall we wind up?
Yes. Yes, thank you, Dr. Vishwa Jayasinghe. It's a very good presentation. In fact, it's a very comprehensive presentation, as well as it's very useful in the current setting, especially in our country, whether what we are going to use. We can justify that it's not necessary that this PCI is not necessary to spare the resources. So a very good presentation, and it's a very comprehensive one. Thank you very much, and thank you very much, Dr. Adhipatran and Dr. Gotabaya Ranasinghe, for being the moderators. Thank you.
Thanks.